Right. Well, thank you, Chair, for inviting me. A lot of this work has really been informed by my interface as a citizen to the healthcare system in the UK. So I have several hats to wear here. I'm a security professor, but I'm a very good listener, and we've generally tried to work with health and social care practitioners to really see if we can create systems which can create holistic care. So this statement here, I think, is one of the key statements that's been made recently. Big data really is such a new area that there is the biggest challenge around it is we haven't developed governance procedures. It's my data that's been used. My big data from my mobile company is being used to track me from where I go to, what I buy, and so on. Should I have some rights to define who uses that? I might say that my data can be used for cancer research, but I don't want my data to be used by a tobacco company and so on. At the present time, the systems we've created are legacy and really have got very little interface with citizens and so on. So I'll show you some research that we did. And normally when we go along to events, we give out clickers and people can vote on certain things. And we found something interesting on some of the questions that we posed fairly recently. So it's a changing world. Like it or not, the internet is just as much part of our life as water, heat, and life. In fact, if you give a teenager the opportunity to take away their heating and lighting or the internet, they'll probably say, well, the last one I'd want is the internet. So it's a critical part of our lives, and it's almost like a thing that is essential to our operation, both our social life and within our business life. And this really illustrates the changing market that I've certainly seen. So the concentration was on network controls. A lot of investment went into IDS systems, IPS, firewalls, and things like that. When I first started working with a hospital, we use ruggedized devices for RFID and so on, and the doctors were given these things, and their nurses would actually clean them. Nowadays, it's bring your own device. A doc will go into a hospital and use their own device. That's the same device as they're using at home or as part of their social life. And that tips security up completely, because the network firewall doesn't exist anymore because they're using 3G. If you find most people now, these events, they're not using the local wireless connection, they're using the 3G connection. So they're right off, the data has been streamed off somewhere else. So the concept of a firewall protecting anything is really gone. And we have devices that we have 64 gigabytes of data walking around with us. I remember computers when they had 1K, a ZX 81 had 1K of memory, and we wrote programs around that, and my students couldn't get out of bed unless they had a few gigs to play with. So we've really moved away from network control, and the investment really isn't around that area anymore. And we're into the point of testers. We're into the point of endpoint security, testing the servers, testing the hosts, and so on. We are. But the biggest growth will be in data control. It's the data that will be king. It's data that we need to make sure that we understand who owns it and who governs it, and who do I trust, and why can't I move my data from one health authority to another, and who's using it, and so on. So it opens up many more questions than it's really answering now. So the big change is around this. And really what it is we're moving from an industrial age into an information age. And the problem is an information age means that anybody can find out anything about me if they want. And we'll see quite in the near future that a police officer can quite easily, possibly, look at my healthcare record, and a GP can look at my criminal record, and so on. So if we open the Pandora's box, which needs to happen, we've seen problems around SOHM, BBP, and so on, the information sharing really happens. Once we open up the Pandora's box, there must be some way to really lock it down for us to get some rights and for us to understand how our data is actually used. So we're really moving from an industrial age into this information age. And the volume of data is enormous. 12 terabytes of tweets per day. In terms of velocity, companies are analyzing 500 million calls per day for their content and so on. And it's 2.5 quintillion bytes of day, which is 1 billion hard disks every day. That's the amount of data that's created every single day. When I first started in security, we did digital forensics. We did it on mobile phones. We did it on disk drives. Doesn't exist anymore. If you're working in the cloud, the data isn't stored there anymore. It's stored within inside the cloud. So it's a changing environment. And the problem we've got is that there's a balance. If we're going to look at holistic care, and holistic care doesn't just involve your GP knowing all about your clinical things. It's just as important that your GP actually knows that you have a problem at home, that next of kin has a drug problem, and so on. So if we're going to try to bring together data from different domains, such as especially from health care, then we need to understand what the governance and what the trust relationships are. When Richard Hammond had his accident recently, 40,000 people accessed his healthcare record. And I know he has problems, but he doesn't need 40,000 GPs looking after him, so on. Tripwires are set up and so on, but we need to understand if we're going to scale our public sector infrastructure across, we've got to watch against the Big Brother society where it's possible to monitor everything that we actually do. Another big problem that we have just now, citizens tend not to be integrated into the systems that we actually have. And if you look at this, it's quite an amusing story in that the government cancelled a £12 billion contract. Imagine any of us being given 12 billion and say, go away and create a big database, and that's basically it. Just allow people to get access to it, and so on. It was legacy at the box. Everybody knew that it wasn't going to work, but they invested so much money. So they cancelled it, and then a little while later, the government have said, within 3 years, we'll all get access to our healthcare records. So now I would not ask everybody to vote here, but does anybody think that within 3 years, everybody in the UK will get access to their healthcare record? Does anybody want to put their hand up? No. Okay, so something needs to change. And it's always quite amusing to look at so this is the Telegraph. So this is a higher quality of person who's replying back here. This isn't your YouTube comments, but this is one of the comments and people wanting access to the records. Who are these people? Are they all hypochondriacs? Why would anybody want access to their healthcare record? And how are they going to be secured? And what's going to happen to take all the comments that your GP has ever made about you? I mean, times have changed. We're a lot more politically sensitive in the nature of the things that we actually say. Are we just going to send out all the information that's been written about us? On the other hand, you get comments such as this. In France, the citizen gets to keep all their healthcare, and then the clinician actually gets a copy of them. And there's an example there where someone went to see a French doctor, and he said that the healthcare record was virtually unusable in the state it is in. I mean, I certainly know with my son, it took him 3 to 4 months to get his immunization record from his GP, and even when he got it, it was actually incomplete. Then we see the flip side is that, again, why would these people want access to the record? Are they all malingerers and so on? And then we get the problem here. What's going to happen with all the comments that a GP has made? Normal for Norfolk was one that was new to me, but I hear it's a term that's used. Funny-looking kid is another one. Good-looking mum was one that these were actually used at one time within GP records. It would be quite worrying for our whole health record to go online. And then you get things like this that will say, and every time I've made this presentation, there's always someone that comes up to me after it and say, look, my mum went through this problem. She had this, and that was diagnosed, and that was all wrong. So this shows an example, is that sometimes we actually do want peer review of what we've been diagnosed and so on. And this shows you an example of someone who hasn't been treated correctly. So I'll show some results that we got from a clicker system, and hopefully that's going to be good. And this was an event of health professionals, and the great thing is that I was presenting on security. I thought there's no way that anybody will come along to my workshop because I'm going to bore them to tears. But it was the most popular one, so it just shows you that clinicians and doctors are getting it, that security is an important part, and electronic records and engagement of the citizen and their families and their health is just as important, because basically it's my health and I want to know about it, and I want to know about my family's health and so on. So this shows that most people don't think the 3-year vision is actually going to happen. It will happen in patches, but it probably won't happen across the board. And then we asked them, and this surprised me, what do you think, what are they going to say here? Do they want all of the record? Do they want a bit of it? They want none of it. It shocked me. I thought it was going to be a summary, but most people, and this was clinical people involved in health and social care, are actually saying only 7% actually wouldn't want access to their health record. And then we asked them, in what situation would you really want it? Because we've seen many, and if you interview anybody on the street, at any given time they'll say, I couldn't care less, I'm healthy, everything's fine, what's the problem? So we keep getting these statistics. Put that only 11% of individuals at any time might want access, and here we go. When you're ill, basically that's when you want access to it. 1 in 5 were saying when you dispute your treatment. But very few really want it all the time. And then we asked them, what's the biggest bump in the road? What is it that's stopping you from doing this? And surprisingly, or not surprisingly, it's people. When it comes down to it, it's basically people that get in the way. They don't want to change the way they're doing things. The DPA gets in the way. And it's unbelievable when you look at most cases, DPA doesn't really get in the way. And it's an inhibitor that shouldn't really be there. So you can see there, the biggest problem is resistance and changing the existing systems. Security, 0. No one reckoned that security was a problem. We keep saying, why can't I Skype with my doc? It's security. Well, tell me the problem and I'll fix it. It's security. It's a big peer-to-peer network. Well, what's wrong with that? So security isn't the barrier, it's the people working with inside. Can you book online? You'll see it's generally patchy. The 15% were from Northern Ireland, as far as I can tell. They have a very good system there. They can actually get online and book an appointment with their GP. And then how many actually communicate? Well, very few people are able to email the GP and so on. And then we said, what service would you like? Mostly, it's basically to book appointments. But you can see across, there is a demand for a whole range of services there. Then we asked them how many logins did they actually have. And I've done this with kids, and it's fantastic. Kids will say, I've got 40 logins, and they'll tell you all the different logins that they've got from them. And this shocked me, and most people have more than 10 logins. I have certainly some logins that I reset every single time because I can't remember the password and so on. 10 logins, more than 10 things I have to remember. And then they said, how many passwords have you got? Not that many. As a security professor, I have two passwords, and I iterate between them. I'm sorry about that. And if something asks me for 9 digits and more, and upper and lowercase, and a tilde, and I just give up. I'll write it down somewhere. So you see there, we have lots of logins. We don't have a lot of passwords. So there's something wrong with this whole login system. And then we said, so I've done this survey many times, even with students, and Facebook used to be the most trusted ever, and Facebook are really dead in the water. What surprised me is that Microsoft is dead there too. And you can see here, well, this mainly people from the public sector. They trusted more the UK access system and so on. But there needs to be a way that a citizen can actually define to use my live account, because that's a password that I want to be known as that. And do you trust your family? Well, I'm a bit worried about the 18%. But most people trust their family, basically. There's a few things that we wouldn't want, but most of the time, we're 24/7 carers, and like it or not, we can't just switch ourselves off. We're worried about our mum and our problems and so on. So this was another thing, in that nobody likes the postal system. Why is it I still keep getting letters through the post telling me that I should go to an appointment and so on? Because I don't want them. Just send me an email and I will respond to that. So you can see here the tablet is going to be the device of future. That's the device that most people are working with. That's their communication with the rest of the world. So the opportunities are there, and the opportunities really are around holistic healthcare. And it opens up a lot of problems in security, because really we've got to open the Pandora's box to be able to allow the citizen to be treated holistically. So too often we get this, that we revolve around the healthcare system and professionals like little planets around a sun, but really it should work that we are the sun, and the professionals should revolve around us. And that requires a massive change in how we actually use the data. And then we could be preemptive. We've been looking at a concept called I'll come back onto it. Something to do with fragile. I'll come back onto it, and maybe somebody can. So the problems that we have around information sharing generally tend to be split into two different areas. One is our technical challenges. Technical challenges can normally be overcome. The problem is really the societal challenges for information sharing. And what we've been working on is really to try and develop trust infrastructures. And what you want is not just digital trust, but you need human trust. To be able to get the two things to work together, you need both things. The problem with digital trust is that too often rights and identities are bound together with an authentication system. And what we need more in the future is a federated identity infrastructure, a trusted infrastructure where you can prove your identity and then you will get rights for certain services. Along with that, you need a strong governance to build the human trust, and you actually need things that people actually want to use as part of their work. So we've been looking at how you can create systems that actually can translate roles and identities and rights across different domains. Keep the data, don't centralize it, don't put all your data into the one place and then let everyone access it. Keep it where it should be and let it be governed. So we've been looking at how you can integrate domains and how you can actually integrate citizens and even more difficult third sector organizations. So the systems that we've created really start at risk. And risk is all about taking flags and data from each of the domains and defining what the risk actually is. So the key areas that we've looked at are in healthcare with basic risk assessors, and then also within child risk. Because a child might be at risk, a healthcare professional will see that they have bruises, a social care worker might see that they are doing low-level crime and so on. Only by looking at the risk assessors from each domain can you actually see that a child might be at risk. So as part of that, we've been looking at the basic risk assessors, and the one we're working on just now is the frailty index. And frailty is a preemptive risk assessor. Frailty starts with data from lots of different domains. If you ask a clinician, there will be 20 different risk assessors. They might be looking at your mobility. They might be looking at your weight, your height. Most people think fragility is an elderly problem. Actually, it's not. Anyone can get fragile. A drug abuser can get fragile. So it becomes a problem about using the data from lots of different domains. and generating some risk assessor from that. So the system that we've built up, and this is what we're building within Living It Up within a Dallas community in Scotland, is a new type of architecture which will create a new healthcare system. And basically, you've got terms of service with all your identity providers, your service that you want to consume, and so on. And what you're really trying to do is to bind all these terms of service together into a contract. So the system we've built up, user accesses, and then a trust framework. We've defined the trust framework. The trust framework defines all the identities and the attributes, the claims that you have to gather to consume that service. If it's a high-risk service, you use multi-factor identity checking. If it's a low risk, you might be just using your Windows Live account. So we've developed a trust framework which will abstract the whole ecosystem, all the roles and so on. And then the user goes and gathers all the attributes that they want. Trust these providers in any way that you want. And you gather your identity. We have a concept in Scotland called a CAI number. A CAI number is your unique identifier within a healthcare system. And that becomes an attribute around your identity. So the user goes, collects these, takes them back to a governance engine, and the governance engine, in the same way that a Cisco firewall will check all the rules that it actually had and provide a yea or nay for the service. So this is the abstraction of it, and if you're interested, we have some online material for that. And I just leave you with these three comments, which were quite interesting as part of that. This comment here was that the doctor looks at them in a strange way when they're actually asked for a healthcare record, as if they were asking for someone else's healthcare record. And then we see the other problems, and there's no money. How's this actually going to be created? And the worrying point of view is that we're actually creating a system which is disparate, in which data is being set up with inside health trusts, and then that data, in some cases, is being soaked off into a central repository that government could sell off our data. There's a massive business model. Big data is going to be the biggest industry ever. So whoever can get our data will sell us off. And that's why companies are so interested in getting our logins and proving our identity. Thanks.